Okay, everybody, good morning. I am Marty Marin, and this is my wife, Michelle, for all of our guests. We manage Trio Maryland, and we like to welcome everyone this morning, not just our regular members, but all of our guests also. Today's meeting is really exciting. We are going to be addressing post-transplant diabetes with Dr. Sidhaye from Hopkins. He is on the line with us right now. So I think it's the first time we've covered that topic in a while. So we are really anxious to hear what he has to say. And I wanted to remind you that our next meeting will be on July the 10th. We have a very special friend of ours coming in from Michigan. He's a professional chef. It's Chef Oliver Hale, and he's a two-time kidney recipient, very active in the kidney community, and he'll be our guest in July. And now I'm going to turn the meeting over to my wonderful wife, Michelle, and she'll continue from here.
Hi, everyone. Welcome summer, right? And today's topic we have not ever covered, and I don't know why, because it's really such an important one to all of us. It addresses post-transplant diabetes mellitus, and Dr. Aniket Sidhaye, the Director of Inpatient Diabetes Management Service at Johns Hopkins Hospital, is our guest speaker, and we really do appreciate his time and expertise. So let's welcome Dr. Aniket, and let's get started. Thank you.
Thanks, Michelle and Marty, for the invitation. I was very happy to hear about this organization, and as I've learned, Googling on the web and just talking to Michelle and Marty, I'm so impressed by the community you all have created, and so I'm really happy to be able to meet you all and share. The topic is about diabetes mellitus, specifically post-transplant diabetes. And so these are the objectives: to introduce diabetes, to understand when it is that diabetes mellitus really develops, to discuss the rationale to treat it and keep blood glucoses under good control, and to emphasize the importance of 4 different components of a treatment regimen. So first off, where does this word diabetes even come from? So I'm not Greek, so I'm not sure if I'm pronouncing this correctly. Comes from a Greek word that means through. So diarrhea means to flow through. Diagonal means through an angle. For example, diaspora means to scatter through. And so there are some more examples there to give you what dia means. And betes means to pass. So diabetes means to pass through. And mellitus, for you Latin scholars, is derived from a word that means sweet like honey. So for example, the word mellifluous means flowing with sweetness. So diabetes mellitus is a group of metabolic disorders with the shared manifestation of high blood glucose levels. And so you might have heard the word hyperglycemia to describe that. And there are different forms of diabetes. They result from a complex interaction between genetics and the environment. And obviously, there are some very special circumstances in the setting of organ transplant as well. So obviously, this implies, therefore, that what is flowing through, normally speaking, is not sweet. So what is it that keeps the blood glucose normal then? And the short answer is insulin, as I'm sure many of you know. Insulin is a hormone that is secreted by the pancreas, and it helps to keep blood glucose normal. And how does this normally happen? So sometimes I've taken a basic approach to kind of explain what happens normally to set us up. So insulin is secreted by the pancreas. It's secreted by most of the pancreas. Its goal is to secrete enzymes that are responsible for digestion. But there are tiny little groups of cells called islets, and they make hormones that are involved in glucose metabolism. And one of the hormones they secrete is insulin. And so we say the beta cells of the pancreas secrete insulin. And what you can hopefully see in this diagram is as you're eating and your blood glucose level is rising because food gets digested, absorbed from the digestive tract into the bloodstream, it falls. And rising in concert with these glucose levels are levels of insulin, shown in blue. So insulin production by the body neatly parallels glucose levels in the bloodstream. And it turns out that what is regulating the secretion of insulin from the pancreas is glucose itself, which, maybe makes sense that somebody designed this system this way. So as the glucose levels rise, the pancreas increases its amount of insulin, and as the glucose levels fall, the insulin levels come down. And so pancreatic beta cells sense a rise of glucose above a level of 70 and then start cranking up insulin production. So you might rightly ask, what is it that insulin is actually doing? Why is it that this insulin is being secreted? And so on the left, you can see a diagram of the pancreas. It's the thing that's making insulin. And these are the main actions of insulin as it relates to blood glucose regulation. So first and foremost, insulin acts on the liver to slow down glucose production. In fact, where it's secreted from in the pancreas, about 50% of that insulin normally is extracted by the liver. And in the liver, it's one of its main roles is to reduce glucose production. And so you might say, well, why does the liver even make glucose? So the body is adapted to make glucose because in periods of starvation, the body has to be able to supply a fuel to organs that need it, like the brain. And the liver has this unique capacity to take complex carbohydrates, break them down into glucose, but also take substrates that are not carbohydrates, so amino acids from the muscle, and make those into glucose. And so one of insulin's important roles is to slow the liver production of glucose down. The other thing that insulin does, very, very important, is after a meal in particular, it tells the tissues, specifically the muscle and fat, to take up glucose from the bloodstream into the cells of the tissue. And so in this way, hopefully what you can see is that insulin helps to get rid of blood glucose from the bloodstream, where it should not exist in excess quantities, and put it where it's most needed. So your muscles can get built up, and if you have too much nutrients floating around, then into the fat, so it can be stored as fat. So this is the major action of insulin. And so probably if you think about this logically, you'll have realized that diabetes mellitus occurs when there is an absolute or relative deficiency of insulin. And that is when blood glucose will remain elevated. So the contributing factors to this are, in the case of type 2 diabetes in particular, a progressive lack of function of the cells that make insulin. Without this, you cannot develop diabetes. The fundamental issue is that the cells that make insulin can't make enough of it for your body's needs. But another very important contributing factor is resistance to the effects of insulin. So it turns out that the way insulin acts can be damaged. And in certain situations, there can be resistance to the effects of insulin. So the muscle and the fat don't take up glucose as well in response to insulin, and the liver doesn't shut down its production of glucose. So these are the main contributing factors to why someone develops diabetes mellitus. So this is just to show you a diagram to kind of express the idea that this is not like binary. It's not on off. So what this is trying to show you is on the y-axis here is the ability of the pancreas to make insulin, so insulin release. And on the x-axis is insulin sensitivity. That's how sensitive is the muscle to, insulin to take up glucose. And what you can see is that even if your muscle sensitivity is declining, if you move left here on the x-axis, as long as your insulin production can go up, you don't develop diabetes. So if you stay on this sort of curve here, labeled normal, you don't develop diabetes. Why? Because your body can crank up enough insulin to handle the extra glucose in the system. But once the ability to make insulin or secrete enough insulin is lost, you get, we call it impaired glucose tolerance. So not quite diabetes yet, but the glucose levels are a little bit above normal. And then finally, you develop diabetes. So you can see that if you can affect insulin release or affect insulin sensitivity, you have a chance of maybe taking somebody who has impaired glucose tolerance or has diabetes and get them back up to normal. So This is just a slide about the criteria that we use to diagnose diabetes. If you have the symptoms of diabetes, so that's excessive thirst and urination or weight loss, and your glucose is above 200, you have diabetes. And really, there are no other tests that need to be done. On the other hand, if you don't have any symptoms, then we use certain other criteria: a fasting plasma glucose of greater than or equal to 126, a test called HbA1c, which some of you may have heard about, and I'll explain, of greater than 6.5%, or you have to go into the lab and do a special test where they make you drink this slug of nasty tasting solution. It's 75 grams of glucose, and then they measure your glucose 2 hours later. And if it's above 200, then we say you have diabetes. Now, one word about the HbA1c. The HbA1c percentage is a measurement of the percentage of glucose that's attached to red blood cells, basically. So there's a protein, hemoglobin, in red blood cells, and glucose can be attached to it. And the attachment is such that the glucose stays there. And there's a way to measure what percentage of the hemoglobin is glycosylated, meaning has glucose attached. So obviously, if there's more glucose hanging around in your blood, then more gets attached to this hemoglobin. What you can hopefully hear in a way is that this is not a direct measure of blood glucose. This is a proximate measure of glucose. We like it because red blood cells typically turn over once every 3 months. So it gives you a sense of what is the average glucose control over a 3-month period of time. Now, the problem is it makes an assumption. It makes an assumption that blood cells are turning over every 3 months. And this is not always true after organ transplantation. And so there are some, researchers and really big transplant groups who don't rely only on the A1C for diagnosis, even though the American Diabetes Association says that an HbA1c greater than or equal to 6.5% is a way that you can diagnose diabetes. So I just think that if there is a reassuring value of A1C present in some screening laboratory result, but then there are some fasting glucoses that have been a little high or some random glucoses that have been a little high, I think it's important to look into it further and not be falsely reassured by an A1C, or similarly falsely concerned by an A1C that might be slightly elevated. Okay, now let's talk about some specific factors during or after organ transplantation that contribute to diabetes. So there is, of course, you could have diabetes before having an organ transplant, but there's a phenomenon called post-transplant diabetes mellitus. So diabetes that really has developed only in the setting of organ transplantation. So one of the first and most important contributors are steroids. Glucocorticoids is another word, and prednisone is, I think, the most commonly used steroid that's used as part of maintenance immunosuppressive regimens. And the transplant doctors know way more about that than I do, obviously. But it turns out that these steroids, they impair the action of insulin. In particular, they have a very dramatic effect on the levels of glucose after one eats. So there are many people whose fasting glucoses are normal, but when they're on prednisone, particularly higher doses of prednisone, later on in their day, their glucoses are extremely elevated. And it's because of this effect of prednisone specifically. Then an important contributor are some of the other immunosuppressant medications, in particular tacrolimus, which is a calcineurin inhibitor, and sirolimus, which is an inhibitor of rapamycin. These are actually toxic to beta cells. So the beta cells that make insulin, their function is directly affected in a negative way by tacrolimus. And so tacrolimus, historically speaking, has been a great advance in organ transplantation and immunosuppressive regimens, but it does have this important effect. Another contributing factor, although possibly not a causative factor, are low magnesium levels. So some of you have experienced perhaps being on cyclosporin and having very low magnesium levels. It turns out that magnesium is like an important component of the insulin secretory machinery. And so finding those low magnesium levels could be also contributing. And finally, illness, inflammation, stress, they all increase the resistance to insulin in tissues. And so there might be periods of time where the glucose control is normal, but there are stressful periods where the insulin requirements go up and people can have high blood glucose levels. All of these factors result, depending on the study you look at, in a rate of post-transplant diabetes mellitus in kidney transplant patients about 10 to 20%, and in all other solid organ transplants of about 20 to 40%. So all of that is to say that diabetes is actually quite prevalent in the post-transplant setting. Depending on what type of transplant, anywhere from 10 to 40% of patients may have diabetes. Now, why do we care about this? Now, in the short term, if your glucoses are very high, how should I say that? The bottom line is you just pee out a lot of glucose. And so the kidney helps your body hang on to glucose, but after a certain level in the bloodstream, it all gets urinated out. But when it does, it draws water with it. And so people experience excessive urination, thirst. They could become severely dehydrated, and this could be a risk factor for stroke. In some select situations, there may be acid buildup. Usually this only occurs with type 1 diabetes and not type 2, but I put it in there because some people do experience this. So this is something like bad enough that you got to go to the hospital because of your blood glucose. Like that's something obviously as diabetes doctors, we never want to see. More subtly related to this loss, you're losing calories. And so for some individuals who might then have a difficulty in maintaining weight, this could become a complicating factor if they're losing nutrition this way. Over the medium term, particularly in kidney transplant patients, but in other transplant patients as well, what has become clear is that there's a pretty strong increase in the risk of cardiovascular disease in people who have diabetes, and in the risk of infection. And the risk is increased enough that it does affect, how people do with the transplant. So that's like a medium term sort of complication. And I put it there, I put these two in bold because the long-term complications of diabetes that many people have heard of, damage to the eyes, to the kidneys, and to the nerves, they occur after decades. And so maybe if you've had diabetes before transplant, this is a relevant question. But if you've had diabetes that started only after transplant, the long-term complications that I mentioned here may not be so relevant. And I think what is more relevant are those medium-term complications. And so I'm not going to talk about cardiovascular disease management per se, but I want to emphasize its importance because diabetes is a contributor to cardiovascular disease risk, so heart attacks and strokes, basically. I think the management of cholesterol and blood pressure, maybe sometimes, I know that I have put it on the back burner in some of my patients, the glucose is under control and we'll deal with your cholesterol later. There's a whole bunch of other meds you're also taking, but I think, once things have stabilized, this should be something to talk about because it's on the sort of 10-year horizon after transplant versus the other complications are 10, 20-year horizon. Okay, so hopefully I've given you a sense of what diabetes is, why it happens, and what some bad stuff that can happen and why we might want to keep the blood glucoses under control. And so how best to take care of diabetes. So I often tell my patients that the management strategy is like a four-legged stool and all of the legs are important. And they include monitoring your blood glucose, taking the medications that are prescribed, but working on two other factors, the input, meaning one's diet. So that's obviously going to affect the load on the pancreas, and the output. How many calories are you expending? How much glucose are you using up so it gets extracted from the bloodstream? That's your activity level. And so this stool that has four legs really needs all four legs. And hopefully what you all can imagine is that if any one of those legs is broken, weak, or missing, then the stool is a little wobbly. And taking care and managing the blood glucose becomes extremely challenging. So I just want to, we as physicians, I think we often talk a lot about medications and we talk a lot about checking your blood glucose, but those other two legs of lifestyle, meaning your activity level and diet, are also very, very important. So monitoring of blood glucose. So first off, I want to say, well, why do this? So one of the important things I think is self-education. So for example, if you check your glucose at bedtime and you check it when you wake up, it kind of tells you what happens to your blood glucose when you're not eating. Is the blood glucose going up? Is it going down? It tells us some information there. Similarly, if you check before a meal or 2 hours after a meal, it tells you about, well, how is your body responding to when you do eat? So one of the reasons to check your blood glucose is just to educate oneself about how it is that these two scenarios can affect blood glucose. The other very important reason is to adjust insulin dosages if one is on insulin. Now, how often one should check blood glucose really depends on the medical regimen that one is on. So if someone's just on one pill for diabetes, I don't tell them to check their blood glucose every day. I tell them to check their glucose on a weekly basis so that they learn something about what's happening to their glucose, and also so that if stuff is about to go off the rails, we can catch it sooner rather than later. On the other hand, somebody who's on multiple injections of insulin would probably benefit from checking their glucose 4 to 6 times a day, and that's what I advise. So I think it's tailored to what your specific medical regimen is. What are good numbers? These are the numbers that I tell my patients. In the fasting state, we target a blood glucose of 80 to 130. And if you check any other point in time in the day before a meal, at least 3 or 4 hours after your last meal, we think the glucose should be between 100 to 160. Now, in every patient, there are unique characteristics. So some people, I really don't want their glucoses to be less than 100, and that's because they're at risk of a low glucose. And in some people where there are special factors where strict management of glucose is challenging, I say, look, as long as your glucoses are less than 180 or 200, we're doing pretty darn good. So, but this is generally speaking the targets that we set for people for blood glucose management. So what are the tools to monitor your blood glucose? Usually people prick their fingers, they extract a little blood, they put it on a test strip, as you see there on the left, and there's a glucometer. They all use pretty much the same technology. There's nothing magical about the technology in one versus the other. And they're all pretty good at measuring blood glucose. In the last few years, I'm sure many of you know that some new devices have become available called continuous glucose monitors. Now, they are devices that sit right there, right on the back of the arm. That's one of them, called the Freestyle Libre. There's another one called Dexcom, which generally people put on their abdomen. And these are devices that have little catheters dangling, plastic catheters, and they sit in the fat beneath your skin. And so they're really measuring that fluid glucose there. So that's why I called it, they're measuring close to blood glucose. So it turns out that the glucose in that fluid does mirror blood glucose, but with a little bit of a delay of about 5 minutes. The advantage of these is specifically for people who are actively managing their diabetes, because it really allows them to keep track of things. And I have found some people who don't really need them, they're just on pills, but they use them and then they learn things like, oh, I used to think Honey Bunches of Oats was a really good, healthy cereal until I realized it makes my glucose go to 275 after I eat it, which they would never have known unless they could check their glucose like many times a day. So these devices do have that advantage. And I want to highlight that. They really do allow for a detailed data review by providers and shared decision-making. So on the right is like a 14-day average tracing of glucose. These devices sample the glucose every 5 minutes. And so what you can see is the blood glucose on the y-axis and going from midnight to midnight, a 24-hour period. And in this particular individual, the glucoses are running kind of high. And then around 12 o'clock, they either get more active or they take some insulin and you can see the glucoses drop. Well, you can see how this could make for a nice discussion with somebody. Well, what are you doing here at noon that helps the glucose come down? And similarly, what are you doing in the evening that makes the glucose go back up? Maybe we can focus our attention on those two spots. The other thing is some of these devices alarm when your blood glucose is low. And so in that regard, they are a safety feature. So let's talk a little bit about medications. Not going to go into too many details here, except to say that the non-insulin medications come in pills or injections, basically, and they all have different modes of action. So based on what I said before, you can think you might want to improve the resistance to insulin. You might want to jazz up the beta cells and make them secrete more insulin. Some of them help reduce appetite, and some of them cause excretion of glucose in the urine. I will say some of the newer medications out there that have actually been shown in the type 2 diabetes setting to have a positive effect on cardiovascular events, so heart attacks and strokes. These are the flozins or the glutides. That's what I'm going to call them. They're medications that either make you pee glucose or they reduce your appetite and make your pancreas secrete more insulin. The flozins are pills, the glutides are injections. In this transplant setting, they have not yet been well studied, and by which I mean large numbers of patients. There are lots of case reports. There is one study that was ongoing last I checked last year, but I don't know how COVID affected that. So I'm still waiting to hear. Maybe it has been published, but I haven't seen it. So they just need to be used with caution is what I want to emphasize here. And I'm happy to take questions about them or anything really. So let's talk about insulin. There are different regimens for insulin. And on panel A, you see sort of a typical multiple injection of insulin regimen where you give a long-acting insulin once a day in green, and you can see kind of what the profile of the insulin effect is. The insulin effect is on the y-axis. And then with every meal, you give an insulin analog, which is a short-acting insulin. And you can see the insulin action is very, very short. And hopefully what this reminds you of is that diagram from before, which showed you in a person who doesn't have diabetes, what is happening to the glucose and what is happening to the insulin. So this tries to mirror or match what would happen in normal physiology. And this is obviously for individuals who really, their cells are not secreting much insulin at all. Sometimes people can get by with just 2 injections of insulin per day. And this is usually these are mixed insulins. So you mix an intermediate acting insulin called NPH insulin that has a duration of action of 12 to 16 hours. And you combine it with regular insulin or an insulin analog that has this shorter duration of action to help you at breakfast, a little bit lunch and dinner. This type of regimen, the one in panel B, is really for people who are very regimented about when they eat. The regimen in panel A allows for a little more flexibility. And finally, there are insulin pumps. These are devices that have a rapid acting analog that are constantly dripping in insulin. And then when it's time to eat, the person says, I'm eating this much, and the pump gives a big bolus of insulin. So these are devices that are worn, and the insulin is being delivered subcutaneously, just as all other insulins are, but via this device. So that's shown in panel C. So I just have one panel about, because some people might be on insulin, and I wanted to remind them about how they work. So what is basically shown here for the short-acting insulins on the left, on the y-axis are the levels of insulin, and here's time going from 0 minutes to 480 minutes. And what you can hopefully see is for these rapid-acting insulins, they're shown in dark blue and in this, I don't know what you'd call this light blue or teal blue color. What you can hopefully see is that they start acting in about 15 to 30 minutes, and by about 90 minutes, they have their peak insulin level. And then over the next, roughly speaking, 3 to 4 hours, the insulin level comes down. So these are for the rapid-acting insulin analogs. You might have heard of them as Novolog, Humalog, or Apidra, and there's now some other brands as well. Just to remind you about what their duration of action is. And then regular insulin, not too many people use anymore, but this is just to show you what regular insulin looks like. Then there are the intermediate and long-acting insulins. And on the y-axis is, let's just call it insulin effect, how the insulin effect is. And then on the x-axis is time, but it's in hours now, not in minutes. And what you can hopefully see in the dark blue and light blue, these are the typical long-acting insulins that people use. You may have heard of the brand names of Lantus or Basaglar or Levemir. they last about 24 hours. So once you give the injection here at time point 0, the level comes up pretty quickly, but it's not a dramatic rise and stays relatively constant for 24 hours. I want to highlight one insulin, NPH insulin. That's the one I mentioned before that has a duration of action of 12 to 16 hours. It's in red. And it, unlike some of the other ones, does have a more pronounced peak effect. And that peak effect, hopefully you can see, is in kind of this 4 to 8 hour range. The reason I mentioned this particular insulin is because for some people who particularly did not have diabetes before transplant and whose diabetes is mostly due to their prednisone, it just so happens that this insulin's duration of action and peak effect mirror the peak and effect of prednisone and duration of action of prednisone as it relates to causing glucoses to go up. So some people can just be on a big dose of NPH insulin when their prednisone is high, and then as the prednisone dose is lowered, their NPH is lowered, and when the prednisone dose is off or really low, they're off insulin. So it's a particular option for whose diabetes is specifically steroid related. So I want to, of course, express some caution regarding some treatments. Well, really the limiting factor for treatment with insulin in particular is hypoglycemia or low blood glucose. And glucose levels less than 70 are considered to be low. Below a glucose of 55, brain function can be compromised and the risk of seizures, coma, and death starts to increase. So there are certain medicines that can cause this. And of course, insulin can cause this. And the reason is once you take a dose of insulin or a sulfonylurea, you can't take it back. So the sulfonylureas are glipizide, called glucotrol, glimepiride, which brand name is Amaryl, or glyburide, which is diabeta. These are the medicines that can be associated with a low blood glucose. So I want to make one mention of glyburide. Glyburide is a medicine that really should be avoided, in my opinion. And the reason is that when it's metabolized, its metabolites are actually active. And people who have a little bit of kidney dysfunction, and many people who've had transplant because of some of the immunosuppressive regimens they do, those metabolites hang around longer and in an unpredictable way. And because those breakdown products of glyburide are active, you can have a low glucose at an unpredictable time. So some of the other medicines have some gastrointestinal side effects, and that's relevant because, if you have nausea and you don't drink enough water and you get dehydrated, that's something most transplant doctors don't like. So those are some cautions regarding the treatments. Of course, there's other side effects that I'm happy to discuss. So one word about lifestyle regimens. I think visiting with a nutritionist to learn about diabetes and diet is absolutely critical. And I think what's important is to have repeated visits to solidify and expand one's knowledge base about how diet affects diabetes. Also, many nutritionists, registered dietitians, also provide excellent education about diabetes and other self-management skills. In fact, many nutritionists are also diabetes educators. Sometimes I don't think we refer enough to our colleagues in nutrition. Finally, I want to emphasize exercise. Obviously you should proceed as allowed by the transplant team, but both strength and aerobic exercise have benefits with regards to blood glucose control. With aerobic exercise, you just have to be cautious. If you're on a medicine that can cause a low blood glucose, you might have to change the dose. So in summary, just to remind you that diabetes occurs when there is an absolute or relative deficiency of insulin. After transplant, steroids and calcineurin inhibitors in particular predispose to diabetes. Their dedicated testing for diabetes is strongly encouraged given the high prevalence in certain settings. You need treatment to prevent the complications, and many different treatment modalities are available, and I mentioned a few of them, but some of them require vigilance for low blood glucose. Also, I want to emphasize the new tools that have made monitoring of blood glucose easier, and they contribute to increased safety because of the ability to alarm for low or high glucoses for that matter. I'll thank you for the opportunity to meet you all and share with you all, and I'd be happy to take any questions. And I think we have exactly as I'd planned, about 35 minutes in.
Great. Thank you, doctor. This was super. I really didn't know a whole lot about diabetes, so it was really informative to me. We do have a question from Gwen saying, my A1C is coming back at 6.6. Am I borderline diabetic? She takes Trulicity once a week. She's a heart transplant patient, and she got this after her transplant.
I see. So in this setting, Trulicity was presumably started because somebody saw some high blood glucoses. And after that, the A1C has come back at 6.6. What I would say is that, yes, technically, that number is consistent with a diagnosis of diabetes if it's been repeated with a blood test. However, because of some of the issues that I told you about, what I would say is that either the diabetes is very mild or should be verified by some other mechanism.
I have a family history of diabetes.
Mm-hmm.
Both my mother and sister died of complications from diabetes.
Mm-hmm.
That's the worst disease I wanted to get. Even after a heart transplant, I was really concerned about catching this. They started me on the Trulicity after I came back with an A1C of 8.2.
Okay.
And I've been consistently coming back with 6. My tacrolimus is 1 in the morning, 1 milligram, 0.5 in the afternoon. And I do have liver issues, high creatinine levels.
Right. Well, I think that, with the A1C of 8, I think probably a diagnosis of diabetes is pretty secure. But I'm sure your doctors have told you, and I hope you're encouraged that the A1C has come down. And that A1C is a typical target A1C for us, less than 7%. So for
Okay.
people that are being treated, if they get to less than 7%, we are quite pleased. So I think, I hope you are too.
This is Nitin Thakur. I have a question. I haven't had a transplant yet, but I'm on a waiting list for a kidney transplant. So is the post-transplant diabetes, does it start when you get into the immunosuppressant drugs? And is it transitory in a sense that if you are taking immunosuppressants and the diabetes starts, as the immunosuppressants intensity is reduced after 3 months or whatever, does the diabetes come down or disappear, or is it once it sets in post-transplant, it is permanent going
That's a
forward?
very good question. Oftentimes we see high blood glucose levels in the immediate post-transplant setting because of the much higher doses of prednisone at that moment, and the particularly high immunosuppressant doses that are given. And so at that point, we generally just say that somebody has hyperglycemia, meaning their blood glucoses are high.
Mhm.
And we wait to make a diagnosis of post-transplant diabetes till 6 months have passed to ensure that some stability has been reached clinically.
Right.
In that setting, if the blood glucoses remain high, or if the A1C is high, then we say that somebody has diabetes. So I guess the short answer to your question is yes, it is possible for somebody to have high blood glucoses, and then 6 months later, they don't seem to have diabetes.
Any statistical information on percentage of the people who have this transitory, hyperglycemia versus the people who have permanent diagnosis of diabetes post-transplant patients?
Yeah, I don't know the numbers in the immediate post-transplant setting. I know that high glucose levels immediately after transplant are extremely common.
No, I mean, let's say 6 months out.
In kidney transplant, it's about 10 to 20% of patients have post-transplant diabetes.
All right, thank you very much.
Okay, let me go through the questions and comments that are on the chat feature first, please. There were some comments about low magnesium that possibly Jim has had low magnesium, and someone suggested he should have that checked, maybe get some supplements. BSF said, I switched to a Libra 14-day system several years ago, and through parallel testing, finger stick versus Libra, There was a consistent reading difference of 10 to 20 points. The manufacturer said it was due to testing cellular fluid versus blood. I don't know if you have a comment on that.
Sure. So for the magnesium, if the magnesium levels are low, they should be repleted. Yeah. I will say, however, replacement of magnesium has not been shown to resolve diabetes. So that's not like, we don't say, oh, take your magnesium and then don't worry about your other diabetes management strategies. But it's viewed as a way of trying to keep things in as optimal a shape as possible. For the Libre system, under the FDA approval, a 10% difference between blood glucose, up to a 10% blood difference between blood glucose and the CGM reading is allowed or expected. So what we find with the Libre device is that in the normal range, typically it reads pretty close to normal. But as the blood glucoses get lower or as they get higher, the variation from blood glucose tends to increase. And the other thing is that there are some medications that can interfere with the Libre device. And it's important to make sure that, you're not making a judgment based on that. Oftentimes also in that first day after you put the device on, because of the trauma of insertion, the device may not be fully accurate. So there are calibration protocols that the manufacturer advises that can be done.
Thank you. And then on one of the slides, you made the comment, you can't take it back. So Carlos was asking, what does that mean exactly?
Sure. What I meant to highlight was the difference between how a normal pancreas secretes insulin versus when you take these medicines. A normal pancreas makes insulin, but as the glucose drops, the pancreas reduces its insulin production. But once you give a dose of insulin, it's not regulatable anymore. So you're stuck with that dose. That's what I meant when I said you can't take it back. Sorry if that was not clear.
Thank you. Abdullah posted HbA1c 5.9 to 6%, but didn't ask a question. I mean, are they asking, maybe Abdullah, can you clarify if you have a question?
So that A1C is in the pre-diabetes range, but again, that's making an assumption about the validity of the A1C measurement in the setting. So if that's the A1C and all the other glucoses on the lab tests are okay, then that's fine.
Okay, thank you. Chris asks everolimus, the effects on insulin glucose levels.
Yeah, similar to sirolimus, it's expected to have a slight hyperglycemic effect. Does not seem to be as much as tacrolimus.
Thank you. What is the difference of definition between type 1 and type 2 diabetes?
Sure. Type 1 diabetes, strictly speaking, refers to a condition that is an autoimmune condition where the immune system destroys the beta cells of the pancreas. We use that term to talk about people who, might have a similar physiology sometimes. So sometimes the word is applied to people who act like they have type 1 diabetes. So maybe somebody who has a pancreatectomy. Strictly speaking, that's not type 1 diabetes. But if they've had a pancreas taken out, they behave similarly to somebody who has type 1. In contrast, so we consider people who have type 1 to really have an absolute deficiency of insulin. Type 2 diabetes patients, they have a relative deficiency of insulin, and resistance to the effects of insulin is a big part of their diabetes. So traditionally, type 1 is diagnosed in childhood or adolescence, and type 2 is sort of adult onset diabetes.
Thank you.
Type 1 is always requiring insulin treatment.
Abdullah, again, the HbA1c, the 5.9 to the 6, 2 years post-transplant, should I take DPP4 inhibitors such as Vilda, sitagliptins?
Yeah, Vilda or sitagliptin. The DPP4 inhibitors are in what I would call a somewhat newer class of medicine. They're not that new, but they are actually amongst the relatively newer class of medicines, ones that actually have been studied in the transplant setting and have been found to be safe and effective. So what I would say is that if those medicines are doing the job, one should take them.
Thank you. Carlos says, thank you. Very informative. My A1C is 5.6. I'm not taking insulin or any diabetes medication. Tacrolimus is at 14 right now. Prednisone, 5 milligrams daily. I drink a lot of water, yet I'm told I'm dehydrated and I have Charlie horse cramps, increasing in frequency. What can I do to decrease the cramps? Also on Valtassa to reduce potassium, ranging 5.5 to 5.9.
It's a little bit hard to know, not knowing kind of the whole story here. I would say making sure that all the other metabolites have been checked. You mentioned potassium, but also magnesium would be important. I think if the glucoses look normal, then certainly those aren't contributing to the cramps, but magnesium, calcium, and potassium are often electrolytes that are abnormal in people who have cramps.
Thank you. Jim, are there any studies on the effects of medical marijuana and diabetes like there are for, say, tacrolimus?
There are studies on endocrine systems with medical marijuana. I'm not sure that I've seen anything that tells me that medical marijuana suppresses the ability of the pancreas to make insulin. So I don't have any real concerns on that front. I'm not sure I've seen the converse though either. I've not seen anything that suggests that it gets better.
He went on to say, I'm sorry, I didn't complete it. He was having other symptoms with the low magnesium, not related to diabetes, but probably the low level issue is related to the tacrolimus, now supplementing with 400 milligrams a day to keep things going well.
That's a typical dose for magnesium replacement.
Let's see, from Kelly, my post-transplant high glucose was pretty short-lived. I insisted that it not be recorded as diabetes on my records because that's a negative thing for anyone looking for new insurance. I made them write medical-induced high glucose instead. I controlled it well enough with diet that by 3 months post-transplant, the only time I needed insulin were the 24 hours post-biopsy because the biopsy protocols prevented me from eating on my schedule. And the food served in the recovery room was so different from what I would eat at home. Interesting. So she's sharing what went on. Christy Simone said, thank you. Abdullah, following to my question, since HbA1c is 6%, my postprandial glucose is always less than 140. Is that good?
Yeah, that's a normal level, in fact.
Once you begin treatment for diabetes, will you ever come off from the regimen? In other words, I lost my space. I lost my, you took it off the screen and I lost my.
Oh, I'm sorry. Did I do something?
No, that's okay. I just lost my, wait a minute, I'll find it. Sorry, guys.
Is this the question from Gwen that said, will the diabetes go away?
Yes, thank you. There you go. Will you ever come off the regimen? In other words, will it go away? Thank you.
That's highly variable. For some people, yes. Perhaps as the prednisone dose comes down, as the tacrolimus is adjusted, perhaps if there are some other modifiable factors such as weight and diet, yes, coming off of the medicines is definitely possible.
Thank you. From Carlos, thank you. Prior to the transplant, I was diagnosed with diabetes, was on metformin. Because of my weight loss and transplant, taken off metformin, magnesium levels stayed between 2.1, 2.2. Are there any current studies regarding the effects of glucose and diabetes in transplant patients? Any of us can he join a study at Hopkins?
We don't have any such studies ongoing at the moment. I know some of the transplant teams have looked kind of epidemiologically at the effect of diabetes in their populations, but there are no clinical trials per se.
A comment from Dario and Sharon, their transplant hepatologist does not recommend medical marijuana. I think that's just because there haven't been a lot of studies with transplant patients. Do you have an opinion on medical marijuana and transplant recipients?
I haven't really looked at it from a transplant perspective. I think that that's the most important perspective. I mean, the diabetes one can always manage one way or the other. But if it has an effect on the immune system, then I imagine the transplant teams would be very, that's a big concern.
Right.
So
Right.
I listened to your transplant letter.
Right. Okay. So from Jim and Carla, are you seeing new patients? I would love to schedule a consultation with you.
Yes, I am seeing new patients.
Okay.
Yeah.
Thank you. Excellent information. Thank you for your assistance. Highly appreciated. Best wishes. Thank you. So are there any other questions that someone, I think, Danette, you said you had your hand raised. Is there a question you have for Dr. Aniket?
I do. The first thing I wanted to talk about was when you said you can't take it back. I had an experience one time where I took my nighttime insulin and my short-acting insulin just before bed, and I mixed them. And I took too much of the short-acting insulin, and I knew I couldn't take it back, so I panicked. What I did was I spent the next 8 hours on the line with CDC every 2 hours, making sure that my glucose didn't drop below a certain amount. And it had in the past dropped below down to almost 40. Wasn't a good feeling. The other thing I wanted to say was I recently had rotator cuff surgery. And at times when it's raining or the weather's bad, I have a lot of pain and I see that my glucose level rises. I am currently on 3 insulins. I do take Novolog, I take Tresiba, and I take Trulicity once a week. That was after my second transplant. I became diabetic after the first transplant. Although, did it kick me off?
No, you still, we can't see you, but we can hear you. There you are.
Okay, I'm sorry. And they told me that I was insulin resistant, but I don't know what happened over the course of time of taking these the different insulins that I take. Right now I'm in the 200s, and that's because of the pain that I go through after taking therapy treatments. And it's not what I eat, because I'm pretty good with what I eat. I wish I could lose some more weight. That'll come in time.
Yeah, I mean, I think, so certainly pain is a stressor. And people who are in pain or have a lot of physical or mental stress, they can have high glucoses during those periods of time. The other thing to remember is that one of the first things I said, and what I tell all my patients is that certainly with type 2 diabetes in particular, is that it is a progressive decline in the function. Now, how fast that decline is different in anybody. But sometimes, there's nothing that anybody did or didn't do in particular that has made the insulin secretion from the cells less. It's just the way it's going to be. But fortunately, we have treatment protocols and paradigms that are effective regardless. But there's no question that diabetes, unlike many other medical conditions where you could just take a pill and maybe watch your salt, for example, for hypertension, or get a surgery, it requires a lot of active management, and it can pose a high burden on people. So we're cognizant of that.
Thank you.
You're welcome.
So Carlos is asking, what is your specialty at Hopkins? I know you had a lot of pediatrics in your
no, that's
background.
I'm an internist. I'm an adult endocrinologist. I just happen to take care of a group of people who are transitioning, who have type 1 diabetes primarily, but type 2 as well, who are transitioning out of pediatrics. That's why it looks like that. But I don't see, people who are growing necessarily. But I would say my focus is on diabetes, on cystic fibrosis related diabetes, and thyroid and bone. So I've within the last 2-3 years, as I've taken care of more patients who have CF, I've become interested in the bone disease after transplant. That's just a small research interest. But what I don't really see patients who have pituitary problems, though. in the endocrine field.
And comments of thank you for the good information. Are there any other questions for Dr. Aniket before he leaves and everyone enjoys the Saturday?
I have one quick one. Is diabetes considered an equal opportunity employer? In other words, is it harder on older people than younger people? Is it more prevalent in, say, African Americans than in Caucasians? I mean, what's the breakdown for who would likely get diabetes? Is it worse if you're overweight than if you're slender? I mean, how does this work? Where do you know you're going to be in trouble with this?
Well, epidemiologically speaking, yes, it's a condition of aging in some ways. So the prevalence of diabetes goes up as one ages, and that's because just as aging causes decline of certain tissues, it can cause a decline in the function of the cells that make insulin. Obesity is a risk factor for developing diabetes because with increased weight, you have increased insulin resistance. But most obese people do not have diabetes. But amongst people who have diabetes, about 80% are obese. So what that means is, what I'm trying to say here is that the key factor is whatever kind of genetic makeup you have, and it's not just one gene, it's many different genes, right? That make it so that your beta cells can't crank up the insulin production at a certain point. That makes that person more prone to have diabetes. It does appear that epidemiologically, yes, African Americans are more prone to developing diabetes, and that may have biological factors, but it may have other factors as well. So, there's a group of risk factors that we take into account when we look at any person who's at risk for diabetes. But in the end, there's no, at this point, what I heard maybe in your question are we able to know, just looking at somebody, gosh, this person's going to have really high glucoses and their diabetes is going to be hard to manage, and this person is not. And the short answer to that question is no, we don't. That is hard to say. Maybe in the next 5, 10, 15, 20 years, as personalized medicine becomes more of a thing, that will become available. But at the moment, there is not.
Is genetics have something to do with it as well? In other words, my mother and sister both had diabetes. My sister's daughter, I think, is probably going to head toward diabetes only because my mother and sister were both overweight.
Mm-hmm.
Had high blood pressure.
Genetics has a huge role to play, particularly in type 2. Sorry, genetics has a huge role to play in type 2 diabetes.
Okay.
So it's strongly heritable.
Okay.
Okay, thank you. Carlos, in my pre-diabetes stage, are my tremors due to the steroids or the tacrolimus? And then Kelly said, both prednisone and tacrolimus cause tremors in many people. So I don't know if you have an additional comment.
From my experience, and my guess is the transplant folks know a little bit better, but because they say all the patients with transplant versus I only see the ones that have diabetes or bone disease, I would say it's probably the tacrolimus.
Thank you. From Jim, can you say something about the mechanics between obesity and diabetes? You touched on that some.
Yeah, I think we touched on that a little bit. As you're overweight, you're more insulin resistant, so that if your beta cell then also can't respond to that insulin resistance, you put yourself at a higher risk of developing diabetes.
Well, great. Dr. Aniket, thank you so very much. Thank you for taking the time to answer all these questions.
And we want to thank everyone that
You're
signed
welcome.
up to come
Thank you for
today.
having me.
Thank you. Everybody, have a great Saturday. Have a great weekend. Stay safe. We hope to see
You too.
soon.
Thank you, everyone,
Bye-bye.
for coming today.
Bye-bye.
Thank you, doctor.